Hello and welcome. It's time for our Doctors Roundtable this week. Questions swirling around COVID 2.0 and increasing number of viewer concerns being registered. Today we'll have a stellar panel of top doctors answering all your queries. Joining me on the Doctors Roundtable, Dr. Hemant Thakkar, one of Mumbai's top consultant physicians, consults in several top hospitals there. Dr. S. Swaminathan, Director Infectious Diseases at Gleneagles Global Health City. Dr. Anupam Sibal, Senior Pediatrician and Group Medical Director at Apollo Hospital Group. And Dr. Lancelot Pinto from the PD Hinduja Hospital, Consultant Pulmonologist, again one of Mumbai's leading doctors. Appreciate all of you joining us once again on the Doctors Roundtable. We've got tons of questions, doctors, for you, and I want to start straight away with the focus on vaccinations at the top, because lots of questions coming on that. Dr. Thakkar, to you first. What is the logic behind the 12 to 16 week gap for the second dose of Covishield, and where does that leave those who took Covishield with a 4 or 6 or 8 week gap? Is there a marked difference? This, of course, coming at a time when the government has now said have a 12 to 16 week gap between Covishield jabs. Will it make any difference, doctor? What happens to those who've taken it at 4 or 6 or 8 week intervals?
So let me answer your latter question first. Let me reassure everybody who has taken it at 4, 6 or 8 week intervals, there's no problem. You've got your antibodies and they will stay for the same amount of time. The answer to the first part of your question, that you can prolong the length of your doses interval. Well, you know, as time goes by, more and more data is accumulated where they take blood from people who've received the first dose and then they take it at intervals of 8 weeks, 12 weeks and more. And they've found that antibodies are still present after 12 weeks. So if you took a second shot, say at 16 weeks, it'll work as a booster. We're thinking on our feet. COVID is teaching us to learn every day. And that's what we are doing. So if they want to increase the gap from 12 to 16, let them do that. But the people who've already taken it, don't sulk. You're still sitting pretty. You have both the doses and you have the certificate. So be happy.
Very quickly, therefore, Dr. Thakkar, as a follow-up to that, Santosh Mehrotra, professor, asked, do people who took the second dose between 6 and 8 weeks need a third dose, a kind of booster? Do I need a third booster dose at all, Dr. Thakkar?
So let's discuss this after maybe Ganpati this year, because if you do need it, it'll be after 6, 8 months. And we will know a little more about immunity, human response, Covishield, Covaxin, what have you. Even the US is not sure whether they want to inoculate with a booster dose. But if we need it, we'll come back to you. ICMR scientists and everybody who have a responsibility will come back to you.
Okay, so for now, 2 doses seem to be enough, whether you've taken it after 4, 6 or 8 weeks. 12 to 16 could be better, but I think that's answered that question. And I want to stay with vaccines. Dr. Swaminathan, the question for you, and this is being asked by a number of people. If I had 1 dose of the vaccine and then get the virus after a couple of weeks, when am I valid for the second dose? Some advisories suggesting 90 days, others 4 to 6 months. Is there an ideal period? If I take 1 dose and then get the virus after a couple of weeks, how much can I postpone my second dose for?
We have some amount of information on this, and some of it is based on modeling. What we do know is that people who have COVID one time around, they tend to have immunity against developing COVID again very quickly, probably for about 3 months. Whether it will stretch to 6 months is probably based on mathematical modeling rather than real data. But if you have 1 round of COVID, you're okay for 3 months. So you have at least a 3-month period cushion to take the vaccine. If you've already had 1 dose of the vaccine and you've had COVID, it's very possible that the COVID acts as the booster to the first vaccine itself. So you may have a little more than just 3 months. So I could model it and say maybe 6 months is okay. But since the data says 3 months, I would at this point say 3 months is best. It may be okay till 6 months, but I'd like to see a little more data to say that I'm comfortable with the 6-month recommendation. Certainly a 3-month recommendation is okay.
So 3-month recommendation as of now, if I get the virus after the first jab, is what you're suggesting. Linked to that again, doctor, is the question, if I got coronavirus few days after getting the second jab, do I have to take a dose again? Was my second dose null and void? I take the second dose and I soon after that become COVID positive.
See, you can get COVID even 1 month after your second jab. See, the idea is that it does protect against corona, but here is the point. It is not a fully protective. In that, it's only about 75% protective, which means there's still a 25% vulnerability. But the most important thing is not about getting corona. See, obviously from a population standpoint, you want to reduce that. But from a personal point of view, it's not COVID that you're worried about. You're risking severe COVID or the risk of death that you're worried about. Now, for that reason, once you got your 2 jabs, you have excellent protection, at least in the near future, against severe COVID or the requirement of hospitalization, ventilation, and things like that. So don't worry about it. Obviously, be responsible and take all the usual protective measures. But having said that, having COVID after you get the second dose is not the worst thing that can happen. Obviously, it's not nice, but it's not as bad as getting COVID without having had the vaccine at all. So no, that does not worry me. It's a nuisance, but not as scary as COVID in an unvaccinated person.
A lot of these questions are coming because there are people getting reinfections. Dr. Lan, sorry?
I just wanted to comment about
Dr.
what
Lancelot
happens after
Pinto,
vaccination based on our study.
Yeah, please go ahead.
Yeah, thanks, Rajdeep.
Please go ahead.
So, we completed a study 100 days after vaccinating our healthcare workers at Apollo Delhi. So we looked at 3,385 healthcare workers, doctors, nurses, technicians, what have you. And we found that 2.62% of them developed COVID within 100 days. But the good news is that only 2 of them required admission. So the admission rate is 0.06%. And nobody went into ICU. Nobody had serious complications. So 2.62% got infected, but admission was 0.06%. And that's what we've been trying to say. You don't get seriously ill if you've had the vaccine. In the vast majority of cases, you don't require hospitalization, or even if you require hospitalization, you don't require an ICU, and your life is saved.
That is very, very reassuring. I just want to come for a moment to our pulmonologist, because one of the concerns is reinfection. And Dr. Pinto, maybe you want to respond to that. Is the high rate, and the high rate word can be subjective, is the high rate of reinfection a suggestion that antibodies from the first wave of the virus are not working against the second wave? Those who are getting reinfected, should they be particularly worried, Dr. Pinto? What does it suggest?
So studies done even after the first wave looked at antibody decay, which is what is the rate at which the antibodies decline over time. And it was found that roughly every 36 days or so, the antibodies halve. There's a halving of the antibodies, which suggests that it is to be anticipated that with time, antibodies are going to decline. Now, there was a hypothesis that despite the decline in antibodies, there is something called a cell-mediated immunity, which will still protect you from reinfection. And that does seem to be the case for a majority of individuals. So reinfections, although they are a lot more common this year compared to what we saw during the span of last year, they still are a reasonably rare event. So if you look at even the seroprevalence data, for example, in a city like Mumbai, the highest seroprevalence was in the slums, and they seem to have the lowest rate of infections this time around. It's the high rises which have the most number of infections, suggesting that seroprevalence did offer a certain level of immunity. But yes, reinfections are being seen more commonly this year as compared to what we saw during the time span. So I think the overall idea is that you will have a reasonable amount of protection for up to 6 to 8 months, but after that, it is likely to wane. And after that, which is why the vaccine probably plays a very important role, despite the fact that you had COVID last year.
Let me bring in Dr. Subramaniam again, because you can, as an infectious disease specialist, take a look at one more query that a number of people are asking. Now we've got the Sputnik virus also, Sputnik vaccine in the market. Can the Sputnik vaccine be mixed with the dosage of Covishield or Covaxin? Are you recommending at any stage, Dr. Subramaniam, any mixing of vaccines?
Not yet. Although the theory in it is very, very interesting, I would still wait for data to come out to say which ones can be mixed and which ones cannot be mixed. See, in general, as long as it's the same target, you could think about mixing vaccines. In fact, this concept of mixing the Oxford and the Sputnik vaccine has been discussed more than 6 months ago. Unfortunately, given that there's a lack of data, I would still wait on it. Your best bet is to stay with things which have been well studied. You really don't want to be the guinea pig unless you don't have a choice.
Okay, let me turn to children because we have a top pediatrician also with us, and I want Dr. Sibal, a lot of concerns over children because there's talk of the third wave affecting children. Here's a question for you. Since children can't be vaccinated at the moment, what are the precautions you advise to keep them safe? Should the babies at any stage, any precautions for them, difficult to mask them? So what would you recommend to keep babies safe?
Yeah, extremely important. So what can we do? The first thing is the parents should get vaccinated, and that'll protect them, and in that way they protect the children. Second, the advisory is coming about vaccinating pregnant ladies. There's a clear advisory of vaccinating mothers who are feeding. I think we need to teach our children, especially the older children, COVID avoidance behavior. So SMS is on. That is something that they need to not just see, but also see implemented by their parents. So the parents need to walk that talk, not just sermonize. For older kids, when I say older kids, even a 3-year-old can wear a mask. It's just that they're not going to wear the regular mask. So if you have a mask with a cartoon or, one of those figures that they're interested in, they are more likely to wear that. And there are quite a few available now. So that's something that we need to encourage. We all of us have been pushing. Vaccination for children is essential. It's just going to take a bit of time. But as you know, Algeria approved the Pfizer vaccine, then Canada, the United States, and now European approval is coming through also for children between 12 and 15. Very healthy, very solid data. The Covaxin trial for children between 2 and 18 has been approved.
Right.
So I think we're going to get some data on children, and we hope that this time around, the data will come faster. And we will be able to roll out the pediatric vaccine, because we cannot have such a large population in our country vulnerable, because our pediatric population is huge. After all, we do have 25 million births a year.
Doctor, I just want to, just a couple of quick answers to related queries. Can COVID positive mothers breastfeed babies? Yes or no?
Yes.
Okay.
Yes, they should.
And is it safe for pregnant women to take the vaccine?
I think we have an advisory to that effect now. It started in the US, then it got approved in UK, and an advisory now, FOXI, the Indian Society, had recommended. We have an advisory about vaccinating pregnant ladies.
And again, linked to that, can women planning to conceive take the vaccine, or should they avoid conception for some time after taking the vaccine? And if so, for how long, Dr. Sibal?
No, I think you can go ahead. There's no correlation between vaccination and planning a family. If we are allowing it in pregnant ladies, so, you should put aside, all such concerns. And also, I might as well add one question which has come on repeatedly about fertility and some of the vaccines. And again, nothing really to get concerned there. And also there was this WhatsApp that floated around a few weeks about ladies not getting, should not be vaccinated during their periods, which again is absolutely ridiculous. So, that's something that needs to be discarded right away.
Very good. I am glad that you're sort of keeping us away from the WhatsApp university of doctors that prevails. Dr. Thakkar, treatment-related questions. A lot of discussion and debate about the accepted line of treatment for the new variant. We've gone through CT scans, plasma, Remdesivir, steroids. Has the time come for a pan-India accepted line of treatment for corona? Do we have one globally? I mean, is there a consistency that is missing? What do you recommend? What is that consistent line of treatment at the moment? Can there be one for COVID?
No, there is a pretty consistent line of treatment. Doctors who know about COVID and who are actively treating COVID are using steroids only on the 4th, 5th or later than that if the patient needs it. Remdesivir has specific indications. Plasma, by and large, has not found favor unless you want to give it within the first 5 days, when the patient has formed no antibodies, but the results are still equivocal. The use of doxycycline, ivermectin, AZI, which are all for 4 or 5 days, is also quite consistently accepted. Anticoagulants or blood thinners are also used, as is inhaled cortisone. The question is, unfortunately, the WhatsApp university, when you're telling a patient you don't need steroids, he says, no, I've taken it because my uncle was given and my aunt were given and they are better, so they take steroids. And 10 days later, they again call you and say, will I now get the black fungus because I took the steroids unknowingly? So unfortunately, poor data being thrown up and churned up by all these WhatsApp messages about black fungus, about first it was use steroid, then now it is don't use steroid. So when you give a deserving patient steroid, he questions you 5 times. And after that, he comes back with black fungus. If you didn't give him in the erstwhile time, they would say, why aren't you giving it? So I think the policy is patient dependent. Each physician, every center knows how to treat. There is no fixed zip line of treatment which you follow mathematically. It is to be decided at the bedside on a case-to-case basis.
You mentioned black fungus 3 times and we've got a lot of questions on it. Let's get it very clear, Dr. Thakkar. Can use of steroids lead to black fungus? How common is black fungus among COVID patients? Should we be, is there a real cause of concern that steroids are leading to black fungus? And what is black fungus?
So black fungus is a growth of fungal material caused by a bug called mucormycosis. But it is so rare that it is the indiscriminate, untimely, excessive use in patients with poorly controlled sugars that causes it. So when doctors with good knowledge use steroids, they give it for a short period of time and they wean and taper them off. Because steroids have a good feeling effect or a feel-good factor, patients often continue them. The black fungus will breed in poorly diabetic controlled patients, patients with elevated sugars for long. It's like keeping bread outside. 1, 2, 3, 4th day, you'll see a line of fungus. So anything that is not properly looked after, whether it is sugar, whether it is excessive use of steroids, whether it is unnecessary over antibiotic use, you're going to get fungus. We've seen patients who take doxycycline from their father and azithromycin from their mother and take both the things. So when they consult us on the 3rd day, they've taken 1 tablet each from the relatives. So they are on 5 tablets because everybody says, you take this. And these are the peoples who saw the branch on which they sit and the branch falls off. If you are enlightened, if you go to the right place, you will have no problem.
Very quickly, doctor, therefore, Dr. Thakkar, the treatment for black fungus and the symptoms that I should worry about?
So if you have been in hospital for more than 2-3 weeks on a lot of high antibiotics, on steroids, and if you are diabetic, and if you've used oxygen for long periods of time, maybe the oxygen has not been hygienically delivered to you. If you start getting unnatural headaches or unexplained sinus pains, forehead pains, visual disturbances, that's when you should start going to the doctor and thinking and asking him whether you have something growing in the sinus, in the orbital area. But that doesn't mean that every headache after COVID is a fungus or a black fungus. It's pretty rare. We are seeing them in single-digit percentages, and that too under 5. So one swallow does not make a summer. If you've been to the right place, followed the right orders, your symptoms of headache, unless the visual symptoms, unless you have persistence of fever and feeling of infection with abnormal blood parameters, you should not run away with this. You know, quite often the fungus is in the mind and not in the body. So that's my saying. Having said that, an index of suspicion on the part of the doctor is very important.
Okay, let me move on to more elements of treatment, because ivermectin has been recommended by the Goa government. They've had to pull back under pressure, under questioning from WHO and others, but they were recommending mandatory use of ivermectin for mild symptom patients. Dr. Subramaniam, is ivermectin, which is cost effective, seen as the first line of COVID treatment? Do you recommend it for those with mild symptoms at all, Dr. Subramaniam?
I recommend it for people who have worm infestations, period. I do not recommend it either as a preventive medicine or as a treatment for COVID, because there's not enough proof either way. All the data that has been put out in the public domain are all either very poor quality data or not even peer reviewed as yet. People are trying to jump the gun. It's hydroxychloroquine all over again. Whether it is useful or not is a later date for us to decide. At this point of time, it's a unnecessary distraction what we need to do.
Well, I hope someone in the Goa government is listening to what you're saying. Linked to that, Dr. Subramaniam, how important is fever management in the COVID fight? Does keeping temperature below 100 the first 5 days help avoiding complications later? Is that critical, keeping my fever down, particularly if I have early symptoms?
See, this is the problem. People are fighting numbers instead of fighting the problem. See, fever is a manifestation of something happening inside you. A bland fever, I'm not worried. An inflammatory fever, I'm worried. See, I have patients who have fever and who are talking to me like I do. And there are people who have not a very high fever, but they look like this and they can't talk and they are tired and they're not able to eat and they have a lot of body ache. That's an inflammatory fever. I know that person is progressing and that person is going to have lung injury. Whereas a person who has a mild fever and is looking up and comfortable and whatnot, I know he's not going to progress. See, not all fevers are created the same. It needs to be evaluated by a competent physician who knows what they're doing and has an understanding of the pathophysiology of the disease to understand when to intervene, what to intervene with, and what to do. Numbers are nice, but I tell my patients, don't throw numbers at me. Show me the story. When did it start? What is happening now? How has it changed? And that tells me where you're going.
Okay. Very, very well put. Let's come to concerns again over those with early stage pneumonia. Dr. Pinto, can a 6-minute walk test help identifying early stage pneumonia among patients being treated at home? What are you recommending, Dr. Pinto, for those who may have early stage pneumonia, in identifying early stage pneumonia?
At the outset, if you have an oximeter, the baseline oxygen saturation alone gives you a lot of information. And if you look at the science, a lot of the studies that have been done, a lot of the drugs that have been tested based on that simple oximeter done at rest. Of course, using a test like a 6-minute walk test essentially means that you're putting your system under demand for more oxygen. So when you walk, your body needs more oxygen. And if your lungs are affected enough, the lungs will not be able to provide that increased quantum of oxygen that the blood requires. So a 6-minute walk test could pick up signs of deterioration at a slightly early stage. It's not necessarily been validated that because a 6-minute walk test is showing a drop in oxygen saturation, therefore you need to do something differently. I would keep the person under a closer watch, under a closer radar, but unless the person still meets the necessary criteria. For example, I would start steroids only when the baseline oxygen levels drop. I would not start it in anticipation of the oxygen levels dropping unless I'm absolutely convinced that this is towards the end of the week, the first week, everything else is pointing in the same direction. There's a strong fever, the person is coughing more than before. And like was said before, unless the patient clearly looks like he or she is deteriorating, I wouldn't be in a rush to start steroids purely based on a 6-minute walk test. But of course, it's a useful monitor to try and kind of realize who are the individuals that you need to keep under the radar.
Right. But I want to link this to a question that is being asked again by several people, Dr. Pinto. How can we reduce complications and deaths among under 45 patients? We've seen with COVID 2.0, a lot of people in that age group of 30 to 45 getting affected, and some of them sadly passing away. So I want to understand from you, how do we reduce the complications? You're saying steroids have to be administered at the right stage, not too early, not too late. But what do you recommend, Dr. Pinto?
So unfortunately, I see the prescription of steroids too early very often. And unfortunately, this demographic in whom it tends to be prescribed too early very often ends up being young individuals. So young individuals, by virtue of having a very robust immune response, by having a very strong immune response, tend to have very high fevers in the first few days. So it tends to be 102, 103. Very often they've been prescribed a cocktail of drugs which may not necessarily be the right thing. But despite that cocktail of drugs, which possibly don't have an effect on COVID and therefore the fever still persists on day 3, day 4, makes these individuals extremely nervous. So they see they're still having 102, 103-degree fever. They are otherwise fine. Their oxygen levels are fine. They seem fine from all other aspects, except the fact that they're having this high fever. And this high fever then drives them to probably tell the doctor that the doctor needs to do something. The doctor feels tempted, therefore, to fix it in some way. And this is when steroids get prescribed very often on day 3, day 4, in the early course of the disease. Now, we know that the early course of the disease is the time when the body is mounting an immune response. And this immune response, let's be clear, this immune response for 85% of individuals is good enough. 85% of individuals will have this fever for 4 or 5 days, sometimes for 6 or 7 days, but will heal by themselves. Now, if you blunt this immune response at this stage by giving steroids, which are immunosuppressive drugs, which reduce your immunity, there is a very good chance that you will deteriorate, that the virus will now have a free hand to multiply. And unfortunately, this does seem to be the story for a lot of young people who come to us in the second week in a pretty bad shape. When we go back and audit their prescriptions, I've seen it more often than not that these are the individuals who've received steroids very early on. So I think, one of the things that we really need to do to protect young lives, is possibly not to react to just strong fevers and have a solid reason to give steroids if we prescribe them in such individuals.
I think you've made a very important point. I think all of you have been reflecting on the need to use steroids very, very advisedly and not just go in for steroids right at the first stage. Dr. Sibal, based on your question on children, a lot of people again now responding. Should asthmatic children be more careful, Dr. Sibal? Are they more vulnerable in any way, Dr. Sibal?
So, any child who has reactive airway disease can have symptoms which can be confused with COVID. So first of all, one needs to make a distinction. Are we dealing with COVID or are we not? So, a test needs to be done, a swab. It's no different in children than from adults to make a diagnosis. And if it turns out to be COVID, then we need to manage as we would manage children with COVID. Of course, someone with, a history of asthma, has been wheezing, would be on medication, which of course needs to be continued, might need to be altered. So it would vary on an individual to individual basis. While on medication, Rajdeep, I'd just like to make a couple of comments. Quite often one sees, parents trying to extrapolate adult prescriptions. And so, okay, I have a 6-year-old, so, I'll give a third of what the adult prescription looks like. And that doesn't work because kids are not miniature adults, and we need to be particular about that. And this is moving away from pediatrics, but some of the drugs that have been really talked about, tocilizumab, itolizumab, and people keep saying, oh, these are magic, wonderful drugs. We have to realize that, yes, they have a role, but clinicians are very careful when we prescribe these because there is a downside to it. So, some of these medications that are talked about really do have a role, but in limited situations and with a lot of deliberation. So that's an important point to take home. Now, what is going to happen in the next 10 days is we're going to get the monoclonal antibody cocktail become available. And that is something that is used in an outpatient setting. When I say outpatients, of course, you need an IV infusion. So you might need to you need to come into a facility to take it. But that is to keep individuals out of hospital. So which means it needs to be given really early in the first few days. It's not something that's going to be used at day 10. So for each of these conditions, and as our panel has kind of clarified, steroids at what stage, remdesivir at what stage, other molecules at what stage, the monoclonal antibody at what stage, plasma very iffy, and so many drugs we've talked about really have no role today as we speak in May 21.
Okay, let me come to a critical issue of monitoring, because a number of people are asking questions, or there are questions swirling around monitoring. Dr. Thakkar, what is the line of monitoring that needs to continue for a few months with recovered patients? Do you feel recovering patients need to do a follow-up CT scan or a blood test after 3 or 4 weeks? What are you recommending for those who recover? And I'll tell you in a moment why I'm coming to this, but your answer to that.
So post-recovery, patients need to be very careful about not contracting a secondary infection in the lungs, which means it could begin with sinusitis and common cold and trickle down into the lungs to have another viral infection or a bacterial infection. So they must guard against going into areas which they are likely to be susceptible to. Having said that, the CT scan, if their CT scan was very bad and was showing a lot of compromise, if their doctor advises, they should do a CT scan not before 4 weeks at least, because the flare in the CT scan tends to increase radiologically after therapy, even while it is resolving. It's like a cube of ice which looks that much, but when it melts, it looks bigger. So if you do a CT scan too soon, you might still see high numbers of involvement and scare the patient. Most important monitoring would be the clinical monitoring. He should look for his respiratory rate, his saturation, his pulse, his ability to do all his day-to-day duties. And if any of that suffers, he should contact his doctor, who will then tell him what to do. But don't ad-lib, do CT scans and blood tests. Yes, you might need one follow-up blood test to look at your CRP, your CBC, and your D-dimer levels. And if things like sugar and kidney are upset, but frequent testing is definitely not the order of the day. You have to be careful for 3 months.
The reason I'm asking you this, Dr. Thakkar, is we are seeing in many cases that even after recovery, the patient suddenly succumbs to the virus or suddenly takes a turn for the worse. They seemingly recover and then take a turn for the worse. Cases of collapsed lungs, massive heart attacks. How can we ensure this doesn't happen? The so-called long tail of COVID has been experienced in some cases. What is the best way to avoid it? How do you ensure it doesn't happen?
So you need to follow up post-COVID with your doctor for as much as 3 months, the frequency of which will be decided by your doctor. You will be given anticoagulants, you will be given blood thinners, you will be given maybe inhalers, and you will be given all sorts of drugs depending on your condition. You might need inhalers with steroids, you might need antihistamines, you might need a low-dose antibiotic for a while. It all depends on your condition. But you certainly cannot say what a lot of people do, that after 15 days, the first question is, when can I go and gym? When can I go for a job? It is these people who had subclinical myocarditis or who had some cardiac or renal involvement, who jump back into the thick of life, suddenly have a problem. So resume activity slowly, watch the next 3 months with a pair of gloves and report to your doctor at least once a month after follow-up, and SOS if required. Don't stop medicine because your neighbor asked you to do it or because somebody said it causes some kind of red, green, blue or black fungus. Take what you're given.
Okay. Okay, so a 3-month period is a critical period, you're saying, where you've got to be a little cautious. I want to come once again to medication because, Dr. Subramaniam, there is still no clarity about Remdesivir, when it should be administered. Let's get this clear. We've been asking this over our roundtables and viewers continue to remain confused. Should there be clarity given by the National Task Force Pan-India when Remdesivir should be administered, Dr. Subramaniam? And what is your recommendation?
See, simply put, people don't understand what Remdesivir does. Remember, it's not the virus which kills you, it's your immunological system. And therefore, the value of Remdesivir is actually very minimal. Studies have shown that in mildly symptomatic or pre-oxygen requiring, there is no benefit at all. For those who require a lot of oxygen, there is unproven benefit. The benefit may be for people requiring small amounts of oxygen. Having said that, I don't worry too much about Remdesivir. I don't even bother using it. If the patient has it, we use it. If the patient doesn't have it, I really don't give two hoots about it because it doesn't seem to make a big difference. The most important thing is the appropriate use of steroids, oxygen, and other supportive therapy. And Remdesivir is not a big deal. WHO has not put in Remdesivir as a key drug for this particular reason. It's not a life-saving medicine. People are going goo-goo and gaga about a drug which does not seem to make a big difference in terms of saving lives. So I'm not bothered. I don't care. It is not important to me.
And why are doctors, Dr. Subramaniam, prescribing Ecospirin after recovery? Any reason why this particular prescription is being given?
Yeah, so it's an extension of the previous discussion, which is so beautifully done. So I will put it like this, that there is an inflammatory cascade, and this is not unusual. See, even after influenza, we've seen this. We know that if you have influenza H1N1 or even other flus, there is a 7 to 10 time increased risk of heart attacks in the weeks to follow. Therefore, respiratory viral infections are known to trigger heart attacks. Added to this, the fact that COVID seems to trigger the coagulatory system, the blood clotting system, more than other viruses, for some unknown reason, is also an additional concern. So for that reason, what our policy has been is that whenever we have a patient who comes to the hospital and requires to be in the hospital for any reason, the minimum that we give them is at least a month of aspirin and monitor them outpatient. However, those who have proven blood clots and things like that, obviously it's much more, you need more than just aspirin. But I think using aspirin for a short duration, especially those vulnerable, there are people who are at high risk for heart attacks like diabetics and hypertensives and all that. So those patients, and we also include patients who had a significant injury, and we give them aspirin for at least a month, and we feel that is reasonable.
Satish Pulapaka is asking, when are we safe to come out of quarantine, Dr. Subramaniam? If we are a mild case and fever free, can I come out after 6 days? Everybody wants to come out of quarantine. So when should they come out? Is there an ideal time?
There are two reasons why we put people in quarantine. One for the society's benefit and one for your own safety. For the society's benefit, after day 5, the risk of transmission is actually quite low. Yes, it can happen, but it's very unusual. But here's the more important point. People may feel well at the end of 1 week, but they can suddenly develop inflammation in the second week, and it can take a turn for the worse. That's why it makes sense for you to take rest for 2 weeks' time. So more than just transmission and your civic duty not to propagate what you have to others, it is also about making sure that you don't do anything crazy or stupid and therefore put yourself at risk. And therefore, it is in your best interest to stay home and take rest for 2 weeks' time. So it's for both reasons.
Okay. Okay, Dr. Swaminathan, and I keep saying Subramaniam, Dr. Swaminathan, you're giving us the answers that we really need at the moment for our viewers. I want to come to virus shedding. I want to come to virus shedding, and want to come to you, Dr. Pinto. Can people who have recovered from coronavirus still be carriers of the virus? Can they pass on the virus to those who have not been infected? I recover from coronavirus. Can I still be a carrier, Dr. Pinto?
So there was this large study which was done in South Africa very early on in the pandemic, where they look at people who remain swab positive for a really long time. And I think the longest duration that somebody stayed positive on that study was 82 days, which was close to 3 months. What they found in that study was that after a period of 10 days from the date of onset of symptoms, there were 0 cases among the contacts of individuals who came in touch with these individuals, suggesting that even though your swab may be positive, even though you may look like you are so-called shedding, you do not for some reason transmit this virus to other people. So it's dead virus that is being picked up by a highly sensitive PCR test, which amplifies that virus to a great extent, and it's dead virus, but the PCR doesn't distinguish between dead and live, and therefore the risk of transmission is low. There is a caveat though to this, that if you've received steroids possibly during the active phase for other diseases as well, like influenza, shedding tends to be longer if you have received steroids. And to the best of my knowledge, we don't really know about transmission dynamics in that kind of a situation if the steroids are given early. If the steroids are given in the second week, as they should be during the immune phase, the possibility of transmission again is very low. So this, I think a lot of people have this question that, should we get swabbed again? Is it okay for me to go out? Or some people get swabbed and find shockingly so that their swab is still positive when they're absolutely fine at the end of 2 weeks and 3 weeks. I think there is reassuring evidence to suggest that even if your swab is positive, the probability of you transmitting it to others after day 10 is extremely low.
Dr. Sibal, one of the worries, and I know because you run a big hospital, is, how long when do I actually want to get hospitalized? Because people are asking, should I, mild symptoms, presumably you're telling all your patients to stay at home, but take a look at this question. Is a deep clean required when home care patients come out of quarantine? Should all my bed sheets be changed? Do all the toothbrushes need changing? What are the precautions that I need to take before I can allow non-infected members to come in? Do you want to take that, Dr. Sibal? Because I'm sure that you are dealing with home patients, also hospital services being provided to people at home as well.
Absolutely. I think it's extremely important to realize that a lot of individuals can be managed very well at home. Sometimes when it's very hard for quarantine to happen at home, hotel is a possibility, and that's why we've got rooms across all the metros where we have a doctor resident in the hotel, and we monitor, and we have nurses, so we are able to provide care. And then, of course, when should you come into hospital? I mean, it's very, very clear. If you need oxygen, we would want you to come under supervision, because how soon or how rapidly you deteriorate is a bit unpredictable. Today is day 500 of the pandemic, and we still don't know precisely who might deteriorate. So if your saturations are down, you need oxygen, you better be under supervision, be under care, so that if your care needs to be intensified,
That's of course if I get a, that's if of course if I get a, that's of course if I, sorry to intervene, that's of course if I get a bed in the hospital. But at home itself, is a deep clean required when a home care patient comes out of quarantine? Do I need to clean all the bed sheets, toothbrushes? What are the precautions I take before a non-infected person comes in, doctor?
So basic stuff, Rajdeep, would need to be cleaned. I mean, you would want to decontaminate, because you will have other people in the home who will be using that room. So basic stuff. But what we are also seeing is like an overdo by a lot of people in terms of the kind of sanitation protocol that they have is sometimes more intense than what we have in hospital, where people have downloaded a whole lot of information and are actually going overboard. So I think there is a bit of common sense that is important here. So we don't want to overdo it, but yes, the basics, obviously, I mean, it goes without saying.
Dr. Swaminathan, is it true that since we are now talking about aerosols in the air affecting and entering the body through the eyes, is it important for me to also keep my eyes covered as well at the moment?
That's another interesting question. We've been discussing about this internally in our infectious disease groups about what is the importance of eyewear and eye protection. Well, it's difficult to say. I think the probability is fairly low. If it was really a problem, then we're all in big trouble. See, most of it is going to be inhalational route through the nose and your tracheobronchial tree. And remember, it's not that the eyes don't have any mechanism at all. Tears do have certain protective mechanism, which does help us to some extent against viruses and stuff. So I think it would be necessary if you're in a high intensity area. So whenever we are in the COVID area, we do wear protective shields and things like that. In fact, I just wear my glasses. I don't wear anything more than that. And yes, but I think it would make sense to wear a shield if you're in a COVID area. Outside of that, I think it's probably an overkill. It's more important to wear your mask rather than anything else.
Okay, I'm in that T20 mode. Quick answers, quick short questions to all of you. Dr. Thakkar, Vijay Kumar asks, it's 4 weeks since I tested negative. All parameters are okay now. When can I take my first jab? I'm 62 years old.
So I think this was answered before. Ideally, you can wait even up to 3 months, but there are people saying you can take it after 6 weeks to 3 months. So depending on your availability, if everything is okay and you wanted to take it after 6 weeks, you can do that. That's not an issue.
Rama Subramaniam asked Dr. Thakkar, can an 87-year-old woman who's a chronic asthma patient for decades take COVID vaccine?
Yes.
Okay. Question, Dr. Pinto, is it common for doctors to prescribe low-dose steroids in the second week? Is that something you spoke earlier about steroids, low-dose steroids in the second week? Sure. Is it common for doctors to prescribe it?
It may be reasonably common, but there is no science backing the prescription of low-dose steroids. If somebody's oxygen levels are low, they should be given what is recommended, which is about 6 mg of dexamethasone once a day, or 32 mg of methylprednisolone, or about 40 mg of prednisolone once a day. A low dose is neither here nor there. So, if you go by the evidence, you give the right dose or don't give it at all.
Okay. Dr. Sibal, should women under 30 opt for any specific vaccine? The United Kingdom is offering women under 30 vaccine options other than AstraZeneca. Is there any specific vaccine you recommend for women under 30?
I mean, there's been a lot of debate about, the Astra vaccine and thrombosis. And even if you look at the recommendations that have come out of different European countries, countries which are next to each other have radically different sort of recommendations. So the question here is, you want to be vaccinated. You need to be vaccinated. You need to do this for your family. You need to do this for your community. You need to do this for your country. I don't think we are going to have the luxury of choices here.
Okay.
So, you're getting a jab, you take it.
Okay. Okay. Dr. Swaminathan, very quickly, how long does the virus shed from a positive person? We are seeing cases where people are testing positive even up till 1 month, but they are still infectious. How long does it stay?
Even Tutankhamun's body has DNA which is detectable by PCR and things like that. That doesn't mean he's alive. So please stop doing PCR tests, people. That doesn't tell you alive or dead. Very simple. For mild to moderate, not oxygen requiring, 14 days is the duration. For those who require oxygen, it's about 20 days. The only exclusion is people who are profoundly immunosuppressed, like organ transplant, in which case you need an infectious disease opinion on duration of infectivity. So very simple, 2 numbers, 14 days for those who don't need oxygen, 20 days for those who need oxygen.
My final question to you, Dr. Thakkar, I have now taken both my jabs. Can I feel free, liberated? Can I now go out, travel? Can I go out and report without worrying about where I am going? As someone who's taken 2 jabs, how immune am I now today?
Just because you've taken 2 jabs, don't forget your mask. Don't forget your distancing. And you're currently in lockdown. So don't be footloose and fancy free. You are relatively protected by about 75 to 80%. You can still get infected. Sure, you won't go to ICU and oxygen and ventilator. But for the rest of 2021, you keep with all the restrictions imposed upon you. Because if you don't, there are people who talk about a 3rd wave, and you will be the reason for the 3rd wave.
So basically you're saying, because the US CDC is saying you no longer need to wear a mask if you are fully vaccinated, you're saying keep wearing the mask, keep taking all the precautions. Am I correct?
I'm saying that in India, because in US there is a very significant percentage of people who have already been vaccinated. But even in the US, the directory is very clear. If you go to crowded places, restaurants or flights, you need the mask. In India, you will be amongst the few percent vaccinated.
Okay.
So till a sizable portion doesn't get vaccinated, don't dream of those fancy things.
Perfect.
Okay. I think we've had a very exhausting session once again. Lots of knowledge imparted, and that's the fascinating part about doing these doctors roundtable, the sheer knowledge and information that you get. Thank you all very much once again to my doctors for joining me and sharing your wisdom with us. I hope our viewers are also illuminated. Thanks for watching. Stay well, stay safe. Namaskar.